Oncology is a branch of medicine that deals with the prevention, diagnosis, and treatment of cancer. A clinical oncologist is a physician who is concerned to manage cancer patients with radiotherapy and chemotherapy. Cancer treatment includes surgery, chemotherapy, and radiotherapy, and sometimes interventional radiology. So, the decision of treatment is a call of a multidisciplinary team. The Clinical Oncology Department, Ain Shams University, accepts about 2,000 patients per year. The journey starts with a proper general and local examination, together with the most appropriate investigations required: tumor markers, radiology, endoscopies, and biopsies, for proper staging of the patient's case to be able to construct the best plan of management of each cancer patient.
The Chemotherapy Unit is involved in the management of systemic therapies, like prescription, administration, and management of toxicities. Traditional chemotherapeutic agents are cytotoxic by means of interfering with cell division, the mitosis, but cancer cells vary widely in their susceptibility to these agents. To a large extent, chemotherapy can be thought as a way to damage or stress cells, which may then lead to cell death if apoptosis is initiated. Many of the side effects of chemotherapy are related to the damage to normal cells that divide rapidly and are thus sensitive to antimitotic drugs. Cells in the bone marrow, digestive tract, and hair follicles, for example. This results in the most common side effects of chemotherapy: myelosuppression or immunosuppression, mucositis, gastritis, and diarrhea, which is inflammation of the lining of the digestive tract, and alopecia or hair loss. Other systemic therapies are also hormonal therapies that target cancer cells that are activated or driven by hormone receptors and block them. Targeted therapies are drugs that target specific molecular mechanisms or mutations and thus are more specific to certain tumors. It doesn't mean they have less side effects. In the chemotherapy unit, we take care of some precautions. Before every cycle of treatment, the duty of the chemotherapy clinic is to evaluate the patient's general condition, toxicities from previous treatment, and do a laboratory assessment, usually consisting of kidney function test, liver function test, and a complete blood count. Clinical pharmacists help in calculating and adjusting the doses, prevent drug-drug interactions and incompatibilities, and then the safe preparation and handling of systemic treatments. Chemotherapeutics and targeted therapies are prepared under sterile conditions in a laminar flow or biosafety cabinet. It is important not only for oncologists but also for other physicians to recognize the adverse events and toxicities that can happen due to chemotherapy and be aware of their initial management. Common toxicities are febrile neutropenia that can happen during the nadir or the lowest level of white blood cells, usually 7 to 10 days after treatment, and needs prompt management according to specific guidelines and according to risk stratifications, high or low risk for morbidity and mortality. Nausea and vomiting and diarrhea that may require appropriate antiemetics and fluid replacement to avoid dehydration. Some chemotherapeutics are cardiotoxic, and symptoms of heart failure or arrhythmia should be recognized and investigated. Renal impairment can happen due to direct nephrotoxicity or due to dehydration and may need a nephrologist intervention. Hepatic toxicity can be presented by enzyme elevation, cholestasis, or liver failure, which may need close collaboration with a hepatologist, especially in viral hepatitis patients.
Every day and everywhere, we are surrounded by radiation. The light we see, heat, radio waves, and microwaves are all sources of radiation. Radiation is also a common cancer treatment. In fact, about 60% of patients diagnosed with cancer get some of radiation therapy. These treatments have one thing in common: all use high energy waves to kill cancer cells. The high energy waves pass through the body to reach the cancer cells, which divide faster and don't obey the rules of the cell cycle division and proliferation. Cancer cells hit by high-energy radiation either die immediately or they die the next time they try to divide. As the cancer cells continue to die, the tumor shrinks. Once we decided that radiation is treatment of choice to our patient, the first thing we need to know is the anatomical location of the target tumor volume we need to treat, and also the surrounding normal tissues and organs we need to avoid. Generally, we start with a CT scan, what we call treatment simulation, where we can acquire a 3D dimensional image of the patient in the same treatment position. Tools that allow us to make sure of the patient position is what we call immobilization, such as the thermoplastic masks in case of brain tumors and head and neck tumor. Another important tool in simulation is the skin marks by special ink that will remain all through the course of radiation treatment. These marks allow the technician to position the patient the same way every day, every session. Go for the next step, which is localizing the tumor and the normal organs around, what we call delineation of target volumes and organ at risk. Arrange the radiation beams around from different angles in a way to hit the tumor and has the smallest possible effect on the normal organs. The last important station in the radiation treatment is the radiotherapy machine, called LINAC. The patient lies in the same position with the immobilizing tool and aligning the skin marks with the laser system. Take an X-ray image by the electronic portal imaging device to make sure again of the patient position. Beam is on and the gantry rotates around the patient. The session takes about 10 to 15 minutes, given once or twice a day, 5 days a week. Patients on radiotherapy are followed weekly for any symptoms or signs of acute toxicities of the skin or normal organs.
Long-term survivors are also a large part of our patients' pool. They may complain from other diseases or comorbidities during their lifetime. These diseases may be unrelated to the malignant condition or related to the same risk factor, like smoking, and should be treated like normal population in most cases. Some long-term toxicities are related to cancer treatments and therefore should be managed by a related specialty in collaboration with the oncologist.